Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk. Glad you all can join us. Excited to see you and excited to take on this topic today. So I will be giving an update about long-acting HIV pre-exposure prophylaxis, or PrEP, primarily focusing on an update about injectable long-acting cabotegravir. I do not have any conflicts or relationships to disclose. I do want to give the disclosure that the agent I will be talking about is investigational, not yet approved by the FDA. I also want to note that what we'll be talking about today comes from a preliminary analysis. We do not have full data yet, so we have some exciting news. We have some things definitely worth talking about. We also still have some outstanding questions, so I will try to highlight where we have data and where we do not. Most of what I'm going to show you comes from this press release and a webinar that was an hour and 15 minutes or so of the investigators discussing HPTN 083 and a little bit about HPTN 084, which I'll mention as well. So if you would like more detail, this was a very informative webinar that is readily available, but I will do my best to summarize it for you, give you my take, some of my interpretations and questions, and then would love to hear your questions and thoughts. And before I wrap up today, I will ask you all to weigh in on your opinion on the potential for long-acting injectable cabotegravir as PrEP. So this is what I will do. I will cover some general notes and focus on what is cabotegravir, then talk about the news from the HPTN 083 trial, the data we have, the data that's been shared, and why it's a big deal, and then finish with some questions, concerns, and thoughts on next steps for long-acting PrEP. First, what is cabotegravir? We've mentioned this a couple of times here on Echo. To summarize, cabotegravir is an investigational integrase inhibitor. One of the reasons there is excitement for it is the potential for infrequent, less than daily dosing and also for parenteral administration. We know from prior studies the half-life with oral dosing is around 40 hours. The half-life with parenteral nanosuspension, so that's IM or subcutaneous dosing, is 21 to 50 days, in some studies even longer than that. In the studies we have, it does appear to be longer in women compared to men. But really what this gives us is the potential for long-acting parenteral administration, either for treatment. We've talked about some of the data around treatment with IM cabotegravir plus long-acting IM rilpivirine. FDA reevaluation of that combination for treatment is pending. Today, we will focus on injectable long-acting cabotegravir as pre-exposure prophylaxis. Now, one thing about the long-acting administration is it's certainly exciting. The potential for less frequent dosing is very promising, and there's a lot of reason to be excited about it. It also gives me a little bit of pause and reason for concern. The reason being, after discontinuing this long-acting injectable, levels remain detectable in the plasma for many weeks. Per one study, the median time from discontinuation of IM cabotegravir to undetectable plasma levels ranged from 43 weeks in men to 66 weeks in women. And somewhere around 17% of men receiving long-acting injectable cabotegravir still had detectable levels at 52 weeks. So a year later, the drug is still circulating in the plasma to some degree. So the question I would pose to you is, what are the risks of long-term, lingering, detectable yet subtherapeutic levels for individuals who may be exposed to HIV, and how can we prevent that from becoming an issue? In other words, how can we make sure that individuals who stop this agent, if it's used for PrEP, or who miss appointments and then are exposed to HIV, do not acquire HIV that has integrase resistance? So I'll just plant that question for you to ponder. I think another promising potential about cabotegravir is it has minimal CYP metabolism, so likely would not have many drug-drug interactions. And then I think one important note is it does not have the robust high barrier to resistance that agents like dolutegravir or bictegravir have. When individuals fail cabotegravir, they do so with a resistance pattern similar to raltegravir, so Q148 and 155, those major integrase mutation pathways. So I think that is another potential area for concern. This is what injectable long-acting cabotegravir looks like. I've shown you this photo before. This image came from Rafi Landovitz at UCLA. Rafi led the HPTN 083 study and is the primary discussant in that webinar I mentioned. Rafi is a friend of HIV Echo here and gave a talk a year and a half ago about the future of PrEP. And so you can go back and see that online. And we've been very, very lucky to be able to collaborate and interact with Rafi over the years. So let's talk about this trial that Rafi led, the HPTN 083 trial, and let's talk about why it is such big news. So another slide from Rafi. So this is the overall design. So this is a phase 2b3 double-blind safety and efficacy study comparing injectable cabotegravir every 2 months, and I'll show you some more detail about this, compared to daily oral FTC TDF or oral Truvada, so Truvada-based daily, as HIV pre-exposure prophylaxis for men who have sex with men and transgender women. The target enrollment was 4,500 cisgender men and transgender women who report sex with men and are estimated to have high risk of HIV exposure. And the primary outcome is HIV prevention effectiveness of cabotegravir compared to daily oral FTC TDF. You can see here the sites around the world. The webinar slides do give some more info about the sites that participated. Here's a little more detail about the protocol. So of note, this is not only a double-blind RCT, this is also what's called a double-dummy RCT. And I think this is an interesting note. So there's no placebo-only arm here, but there are 2 arms that may deliver effective HIV pre-exposure prophylaxis, both combined with placebos so that individuals enrolled in the trial do not know which arm they are in. You can imagine if you just randomize people to a pill or injection, they would immediately know which arm they were in. But here, individuals got oral CAB daily plus an oral, basically Truvada placebo, or oral FEC-TDF Truvada plus an oral CAB placebo for 5 weeks. This was the oral lead-in period to make sure individuals tolerated the medications. And then they received either IM injectable cabotegravir every 8 weeks plus a daily oral placebo, or oral FTC-TDF daily plus an IM placebo. So everyone in the trial got an every 2-month IM injection plus a daily oral pill so that it was completely blinded and no one knew which arm they were in. Importantly, I mentioned the lead-in here of 5 weeks of oral dosing. Individuals who transitioned off the IM injections then got a full 48 weeks of oral FTC TDF. That was the post-injection tail, if you will. Again, because levels of the IM cabotegravir can last in the system for up to a year, that was the tail that was recommended after completing the injection. So that is not a trivial amount of oral dosing after completing the part of the study that included IM injections. Here is what we know about the study population, and I think there are a few really important things here to highlight. So we do not have full details here, but this is what has been shared. The overall number of participants was over 4,500, so met the study goals. Again, high-risk men who have sex with men and transgender women enrolled. The average age was 28. You can see here that the overall engagement with young at-risk individuals was really excellent. Also, I think that the overall engagement with trans women and those individuals in the US who self-identify as Black or African American is really, really excellent and way higher than in most RCTs in this country. So I think this was a really substantial and outstanding effort to engage individuals who are at risk HIV and have just disproportionately high risk compared to other demographic groups. And here is the key finding and the reason this is such a big deal. So this is the number of infections that occurred in the oral daily FTC-TDF or Truvada arm and the number of infections that occurred in the every 2-month IM cabotegravir arm. 38 infections with oral FTC-TDF compared to 12 with IM cabotegravir. So overall, 3 times fewer infections with IM cabotegravir. You can see here the incidence in both arms as well. Now, a couple of important notes about this. So this really clearly documents non-inferiority. This trial was not designed and not powered to assess for superiority of cabotegravir over FTC-TDF. So we cannot look at this and say IM cabotegravir is better than oral FTC-TDF. We can say that it is clearly statistically non-inferior. In the webinar, they do highlight that the DSMB who did this analysis did use the terms this approached statistical superiority. So I think, again, we'll get full data in the future, but I think there is a lot of reason to be excited about this. Importantly, there was no placebo-only arm, so we do not know exactly what the incidence would have been without any pre-exposure prophylaxis. But the investigators used modeling, and based on risk factors for the participants who enrolled, they estimated the HIV incidence would have been around 4.5%. The actual overall incidence was 0.79%. So really showing that in both of these arms, effective HIV pre-exposure prophylaxis was documented. Both of these options were effective for prevention of HIV. Again, the punchline is that IM cabotegravir appears to be non-inferior, and there's some intrigue around the fact that there were even fewer infections and that the analysis approached, or the results approached, statistical superiority. So what does this mean? This means that the DSMB actually recommended that this study be unblinded, that all participants be made aware of the results and be given the option to transition to IM cabotegravir. So this is a huge deal. It is a very complicated time, as you know, and some of the study sites have definitely been disrupted by COVID-19 and the pandemic and crisis. But the DSMB and the investigators also noted that this data came before those disruptions. So I do not know exactly what's going to happen with this trial moving forward. But I do think that this is very exciting data and really shows the potential that we may have a long-acting injectable option for HIV PrEP in the relatively near future. Thinking about side effects and adverse events, 3 adverse events were more common with the IM cabotegravir injections. Injection site reactions of any severity occurred at about 80% of those individuals receiving the IM cabotegravir, compared to 30% of those receiving IM placebo injections. That said, the majority were not severe. Only 2% of individuals receiving IM injectable cabotegravir stopped because of those injection site reactions. So this is really consistent with what we've seen from other trials of IM injectable cab. 2 other adverse effects that were more common with injectable cabotegravir were pyrexia, elevated temperature, and elevated blood pressure. The investigators noted that what they do not know is, did those occur at the same time as the injection site reactions? So were these independent of individuals coming in with painful injection site symptoms, or were they all occurring together, which would make sense? So we'll see more about that in the future. Some questions and concerns, a couple of which I have mentioned, a couple of which the investigators brought up. So one, is the oral lead-in necessary, and if so, for how long? The study leads brought up this question of, could, quote unquote, direct to inject be safe? I do not know what is going to happen in the future to assess that question, try to answer that question, but I think it is a very worthwhile question to ask. And then again, how long of an oral tail is necessary after stopping the injections, or if a person stops showing up for their injections, what is the best strategy? What is the best agent for the oral tail? As I showed you in the trial, 48 weeks of oral FTC-TDF is what was recommended. And again, what are the risks of the missed doses? So what we really do not know yet is, why did the 12 HIV infections in the IM cabotegravir arm occur? And what was the timing of those infections? So did those all occur, right before that 2-month follow-up injection? Were levels waning? Did they occur in individuals who had missed an injection? So we have not seen analyses of the cabotegravir levels in those who acquired HIV infections, and that will be important. They have done some analysis of drug levels in the FTC-TDF arm and have shown that overall adherence in the trial to FTC-TDF was quite good. However, they also have not looked at TDF levels in those individuals in the Truvada arm who acquired HIV. So there are going to be more detailed analyses coming for sure of drug levels, of factors that led to the infections in both arms, and then also whether the individuals who acquired HIV acquired resistance. We do not know anything about potential cost for IM Cabotegravir or FDA evaluation and potential approval for pre-exposure prophylaxis. Also, I think there are some questions about the clinical logistics. Initially, there was excitement that IM Cabotegravir's PrEP might be feasible with every 3-month dosing, and then the PK data didn't support that. So this is every 2-month dosing. So what we're talking about here is individuals coming to clinic every 2 months for IM injections, which for some certainly may be preferable over daily oral pills. For some, certainly might present barriers. And then we also, I think, need to consider what we would do in terms of every 2-month injections plus every 3-month follow-up for HIV tests, for STI testing, things like that, and how we would strategize to make that feasible both for the person receiving the injections and for the clinic. There was no comparison here, of course, to oral FTC TAF. And then there is this question about every ARV study these days about weight change over time. A small amount of prior data showed that IM Cabotegravir did not lead to weight gain in men without HIV who were receiving it. However, there was no comparison group. So I do anticipate we will see a comparison based on this data in the future. So what's next? I think a lot of those analyses and looking at some of those details in this trial will absolutely be done. This companion study, HPTN 084, is currently ongoing in sub-Saharan Africa. This trial enrolled cisgender women. This study, a similarly designed RCT, started about a year after HPTN 083. So the DSMB did a similar preliminary analysis. They did not find any safety concerns. They did advise that the trial should continue, but they had not enrolled enough participants, and they did not have enough data for them to find any differences in the analysis or do similar as with 083 in terms of recommending that they stop and unblind. So waiting for more data on that. Importantly, in that study, investigators will assess for superiority of IM Cabotegravir versus oral FTC TDF. We talked that in December, the FDA did not approve long-acting IM Cabotegravir, a rilpivirine combination for HIV treatment. We do not know the exact timing of the FDA reevaluation of that, but rumor has it will be within the next couple of months, so stay tuned for more on that. And then certainly there's excitement about other long-acting PrEP agents, some of which may be able to be dosed yearly with implants and with other more convenient strategies. And so I think my summary here, and then I'm going to ask you a question, then would love to hear your thoughts and comments. So this prelim analysis demonstrates that IM Cabotegravir every 2 months is statistically non-inferior to daily oral FTC TDF. I think this gives a lot of cause for excitement. I think there's potential for enormous benefit, easier adherence, reduced side effects. I don't know for sure, but I anticipate this would be an option for individuals with significant renal insufficiency. I also think that giving individuals options that do not require keeping a bottle of Truvada around the house and that reduce stigma, reduce fear of intimate partner violence, this is just huge and has the potential for enormous benefit.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.